Ideally, the geriatric patient would be obtaining care from all providers simultaneously. Really, we are in an all-hands-on-deck scenario for the common multi-complex older adult. They need geriatricians and nursing, caregivers and family, psychologists, CNAs, dentists and dental hygienists, PAs, social workers, dietitians, occupational and physical therapists. The whole smorgasbord of healthcare professionals should ideally be involved in the care of patients like Mrs. Cologne. And as we'll see, outcomes actually improve when we do this in the right way. Complex needs require a team-based approach. Geriatric patients are complicated. Multiple comorbidities with multiple contributing factors. Multiple treatments are needed, and multiple professionals are required. And of course, care quality is improved when a multiplicity of professionals are working together to handle the multi-complexity of the patient as an interprofessional team. And team is the operative word. We really need everyone all together. And so let's take a minute to define interprofessional team-based care and how it differentiates from some of the other common words you might be hearing in the healthcare environment. So first, multidisciplinary teamwork. So multidisciplinary teamwork is similar to interprofessional teamwork, but it involves different disciplines rather than professions. For instance, on our bridge team, in addition to being interprofessional, we're also multidisciplinary. In addition to healthcare professionals, we also have a really gifted medical anthropologist on our team who's in a completely different discipline but augments and amplifies our care and education dramatically. And information is shared across disciplines, but they don't sit together in multidisciplinary teamwork and formulate a team plan together, all right, a team treatment plan. And this is differentiated from interdisciplinary teamwork, in which people collaborate across different disciplines rather than healthcare professions. And information is shared across disciplines, and the disciplines do work together to form treatment plans, similar to our own model. And in interprofessional teams, we're talking mainly about interprofessional teams of healthcare professionals that are working together as a team with clear roles and shared treatment planning. So everyone is on board working together to get to the goals that the patient has for their own care and that we have as healthcare providers. And of course, I want to take a minute to talk about interprofessional education versus interprofessional practice, because as we know, the environments that we train in as trainees, as students, we are more likely to adopt as we move into practice. So it's really important that we not only, as practicing providers, learn to practice in interprofessional teams, but that this training start much earlier on as people are moving through their different professional schools and into practice. So interprofessional education, much like interprofessional practice, is an activity that occurs when members or students of trainees of two or more healthcare professions engage in learning and clinical training together. And interprofessional practice, in comparison, centers on the actual provision of patient care in an interprofessional team. Interprofessional education is becoming more and more formalized and has gotten national and international attention. There are, of course, core competencies for this educational programming, of which we also adhere as part of the Bridge program. You'll notice in the handouts regarding these sessions, our self-learning modules, that all of the interprofessional education collaborative core competencies for each module are included. And these cross the values and ethics for interprofessional practice, roles and responsibilities for collaborative practice, interprofessional communication, and of course, interprofessional teamwork and team-based care. Interprofessional education and training started back really in the United States intensively with a round of federal funding that encompassed both the VA with a program in the 1970s for interdisciplinary team training in geriatrics, and crossing into the 80s and 90s with two HRSA programs, the Geriatric Education Centers and the Geriatric Academic Career Awards. The Geriatric Education Centers are the precursor to our current funding that brings us here today, and the Geriatric Academic Career Awards are K awards designed to train interprofessional healthcare professionals to become leaders in geriatrics education and care. And this is the award that I currently am working on here at Downstate. And this, of course, there's been other iterations, including the Hartford Geriatric Interdisciplinary Team Training, which advanced through the early 2000s into the 2013 Geriatric Workforce Enhancement Program, which was designed by HRSA, and which we are now funded as part of the Bridge program. But let's now take some time and turn to the models of care that currently exist. What are the evidence-based models of care that you as a student, trainee, or provider might use to improve the quality of care in your practice environment and improve the outcomes for older adults here in Brooklyn? And of course, there are disease-specific, program-specific, and site-specific models of care. And we're going to take a few minutes to step through these in a site-specific sort of way. And so these are some of the models that are available across different segments of the healthcare continuum, from acute care through care transitions to community-based care and home-based services. First, we're going to take a look at inpatient models of interprofessional care for older adults. And this is one of my favorite models of care for inpatient older adults. And the reason it's my favorite is because it really breaks down some ageist barriers that exist within the healthcare system. And if you take a look at this model, what you'll notice at the very top of this first figure is that in this model, they expect that we take in a functional older person and we discharge a functional older person. And this goes against much of the dogma that you might find in many inpatient units, in which there is some expectation that deficits will accrue within their inpatient hospitalization, and that we have to develop disposition and treatment plans that will handle those deficits. In the ACE unit model, the acute care for the elderly model, we take an older adult who has an acute illness and is going to be hospitalized, and we anticipate the potential deficits that could occur if we don't act early enough, and we prehab those individuals for patient-centered care. We take a look and we create a prepared environment, interdisciplinary collaborative care, interprofessional care, multidimensional assessment and non-pharm prescriptions, med review, home planning, transitional care, and create an entire system of care that then allows older adults to leave the inpatient setting with improved mood, positive expectations, reduced impairment, and decreased iatrogenic risk as compared to care as normal. And of course, as in the ideal scenario, the functional older adult will then be discharged back to their home environment to go on about their everyday life. In your current care system, I want you to stop and think about how that compares to the model of ACE care. And think about ways in which implicit biases might be playing into your dispositions for patients, and how we might improve those outcomes and those models of care and stop ageism within the healthcare setting. And so this is just an outline of ACE care versus care as usual. And there's improved physical outcomes, less disability, less falls, better mobility, improved quality of care, reduced 30-day admissions, shorter length of stay, improved cost, and of course, improved satisfaction. Caregivers, nurses, physicians, patients all have a sense of improved satisfaction in this model of care because outcomes have improved, right? And they're working together with a whole team. And this is comparable to the MACE model, which is a mobile acute care for elders model, which takes the ACE model and basically recognizes that some hospital settings may not be able to dedicate a particular space to have an ACE unit for older adults. So instead they make it mobile and adaptive. And they take the same ACE team and they make them mobile and able to move around the hospital in a consultative fashion and provide the same level of ACE care on regular med-surg units. Same interprofessional team, excellent outcomes. Decreased reportable events, decreased length of stay, and of course, improved satisfaction with care again. And there are programs like the Hospital Elderly Life Program, which is focused on reducing or preventing delirium in elders, targeting older adults 70 years and older with one or more delirium risk factors, and targeting them with 6 protocols that reduce or prevent delirium across 6 different domains. And this is what that model of care looks like. With protocols that are targeting visual impairment, hearing impairment, dehydration, immobility, sleep deprivation, and cognition. This model is really important in the inpatient setting, has been shown to reduce delirium incidence by up to 40%, decreased duration and number of episodes, Unfortunately, there's no difference in severity or recurrence once delirium has set in, but we seem to be able to prevent quite a bit. It's been broadly implemented, and it often is cross-implemented with other programs like ACE and NICHE that I'm going to talk about in a minute. Training and replication resources are freely available online, and I would encourage anyone watching this to take a look. This can be very easily implemented in any hospital setting. And of course, there's a niche model, Nurses Improving Care for Health System Elders, which takes, it's just a nursing care model looking at improving quality of care and nursing knowledge, skills, and attitudes in geriatric care. So this model is focused on improving nursing skills and knowledge when caring for older adults by providing the training and tools necessary for those professionals to be feeling competent in providing geriatric care. They model interprofessional team care, and they provide education on very specific topics which are important for care quality in older adults, including pain management, pressure ulcers, adverse med events, delirium, falls, and urinary incontinence. And of course, this is happening in an interprofessional team setting, and the outcomes include improved quality of care, among others. As you're listening to me speak, let's take a minute and have another brainstorm. How are the 4 M's incorporated into these models? I didn't call them out directly as we went through because I wanted you to go back and think about each of those models of care and how each of those M's is incorporated into each one, and it might improve the quality of care for older adults. Medication, mentation, mobility, and what matters. How might you build a new model that utilizes the 4 M's as at their core? Something that is particular to your environment, perhaps. How might you adapt one of these models to fit your current care environment with the goal of improving the care for older adults? So let's pause the video here for a couple minutes and think about that.